Coming up on the Rig Report.
Today's the day. I'm going to do a podcast. But I guess introductions are in order first before I get ahead of myself. Quick disclaimer before we get into it. The Rig Report is a podcast centered around EMS education, current EMS events, and commentary. This platform is produced by myself and the occasional guest that I might have on the podcast. Understand that the views and opinions expressed here are our own and do not reflect the views and opinions of our respective workplaces. Nor do we speak on behalf of our respective workplaces. Relax, enjoy the podcast, and I hope today at some point I'm at least able to make you think. Alright, so let's get right into it. It's Monday afternoon. My wife's at work, got the house to myself, me and the dog, sitting here with my cup of coffee, and decided that, today's the day. I'm going to do a podcast. And, actually I've been thinking about it for a couple of weeks now. I've been wanting to get into like a YouTube channel, a podcast, maybe some social media presence, because I just want to fill a couple of these gaps that we have. And I'm finding out that people, especially the younger generation, is learning more from these short videos and podcasts and things than they actually do from their instructors. And that makes me happy that, these young people that are entering the field are wanting to learn more, and I guess in a way it's almost their equivalency of reading studies and things like that. Although I wish they read the studies. But I guess introductions are in order first before I get ahead of myself. So my name is Travis. I've been in EMS for over 20 years. Been around it for a lot longer than that. Almost 30 years now. It's like time flies. But my parents, they got into EMS when I was about 7 or 8 years old. Used to drag me to the local squad hall, My experience is more around rural EMS, more specifically on the western side of Virginia. I've kind of got a well-rounded experience. I've been around a few city EMS agencies. Have a lot of people that came from those agencies that have taught me a good bit about them. And, part of the goal of this podcast is to highlight some of the differences between rural EMS and, our more metro cousins. So, that's my story. And, I see a couple of big places where we need to do better. And one of them, of course, is in education. We always need to do that. I'm an educator at heart. I'm an EC through the state of Virginia, and I'm an instructor in several AHA disciplines and other things. And then as the heart of an instructor, I want to, always improve education. But on the other hand, the public, not just the public, other healthcare providers don't even know what we can do as EMS providers. Cue story here. I couldn't get through this without telling a war story. But just for an example, a couple years ago, I was on duty at our local EMS agency. We got a call for a cardiac arrest. We went out. Long story short, there were actually 2 crews ended up getting there for extra hands. And we couldn't get this patient out of the house, not without interrupting compressions and everything, because just the layout. It was one of those places that was just a nightmare to get the patient out of. But the thing that struck me, we were able to perform good team dynamics, really good pit crew CPR. And there was one of the people, or one of the providers there, that was able to keep the family kind of corralled back in another room, but would go in between and give them updates on where we were at and, what was going on. But there was one family member in particular that kept coming back to the doorway and kind of peeking in on us and didn't seem super upset about what was going on. And at the end of the arrest, of course, we didn't get the person back, and we ended up calling it in the field. Was the person that kept standing at the doorway came out, and it just so happened that she was a nurse, and she shook the hand of all of us on scene and talked to the director. Our EMS director was actually on the scene with us, and she said, "Thank you for what you did." But the part that really struck with me was I had no idea that you guys could do these things. She said it was like watching an arrest in an ER. All the things that you were doing is exactly the things that we would do in the hospital. And that struck a chord with me. I was like, really? Like how have we neglected so long getting word out to the public and our healthcare providers and sisters that they don't even know what we do in some hospital systems, and that drives me crazy. So, part of the reason for this is to educate the public, help educate other providers. And in fact, the name of my YouTube channel and my social media presence is going to be PPE, which of course is a play on the, PPE. And it stands for Public and Provider Education. So I want to be able to fill that gap there. And, who knows? Maybe I'll be successful and help educate some of the public. So that's the goal. Okay, so let's get right into it. So, I've picked a fairly controversial topic right off the bat. And I guess that's okay because, that's how we create an open dialogue. You say something that gets people's attention, you get people talking, and that's how you have a good open conversation. So here we are. So I'm going to talk about calling for ALS or overutilization of ALS. And let me go and address this because I know this is going to be an issue. Somebody in the comments, it's inevitable, there will be at least one, if not a few, that are going to get on here and say something about, "Oh, you ALS providers, you're so lazy," and complain about how we're always complaining at you BLS providers for calling us to the scene. So if that's you, let me go ahead and address you right now and stop you. First off, that says a whole lot more about you and where you are in your training and your craft than it does about the ALS providers. Because that's absolutely a nearsighted viewpoint if you can't recognize that there's a problem here. Okay? So my only thing that I can say to you is just hear me out and listen to what I have to say because I have quite a bit of information to back it up. So basically, overutilization of ALS, it's been an increasing issue for some time now, and I can speak on that because way back in the day, kind of telling my age now, the region that I worked in then, we had very few ALS providers. I think there were like 2 cardiac techs at the time and maybe like 2 paramedics in the entire county. And it was very rare for you to have ALS backup. I mean, most of the time I had to learn how to deal with things on my own and take the patient to the hospital. And yes, I know that's more of an issue for the patient. It sucks for them more than it does for me. But being an EMT, I can definitely feel for you about how nervous that'll make you not having another person to back you up if you actually need them. So I get it, right? So the important thing though is the end point of this, the patient outcomes. And that's where, we really need to be looking if we're going to solve this apparent mystery. So according to some studies, we're at one of our lowest points in EMS. Like we're short of providers, overworked, underpaid, the whole spiel. But it's very important now that we understand resource management. Now, if you're one of these people that are, as in like a system that runs dual medic trucks, this doesn't apply as much to you because you don't have BLS providers. So this is not as important for you. In the region I work in, we still don't have an abundance of ALS providers, which leaves some of our units staffed with a BLS crew. So it has become a problem mainly because we have BLS crews that are calling out ALS providers, taking out an ALS truck to come to you for things that really don't need to be considered ALS. And it's a problem mainly because resources are slim. You're overtaxing the system. So you're bringing an ALS truck to you out of service. Two trucks are actually out of service now because you called for ALS backup. Now, don't get me wrong. If you really need an ALS provider to come to your aid, by all means call. However, calling them for these things that don't require ALS has become a major problem. It's happening, and it's not just in our state, not just in our region, it's all over. A lot of people have reported that this happens a good deal. And all it does is overtax the system, and the people who pay the price are on the end user, which is the caller, the patient. So I think the thing that bothers me the worst about it, aside from, resource mismanagement, is probably the way that a lot of these EMTs are selling themselves short. Don't let anybody convince you that you're less just because you're an EMT. I've heard that a lot. A lot of EMTs aspire to be paramedics, and if that's your dream, go for it. And no problem with that. But don't ever feel like you're less, okay? Because EMT is literally the building blocks, the foundation. If you're not a good EMT, you're not going to be a good ALS provider, period. That's just the way it is. And to get into that a little bit deeper, an EMT, when they go through class, they're taught basic anatomy. They're taught how to take care of like your major traumas, your very basic patient care things. When I get on scene as a paramedic, my entire first part of this call is BLS. My treatments are absolutely based on a BLS assessment because I'm going to do the exact same things that you're doing on scene if you're an EMT. When you come in, I'm going to get my patient history, the history of the present illness or injury, and then I'm going to do an assessment. I want, the physical assessment. I want to know what the vitals are, what condition is the patient in. I'm going to do all of these things first, just like you are, or you should be doing, and I can make a good determination with that information, and then then and only then do I decide to start doing my ALS interventions. So to kind of back what I'm saying up, there's several studies out there. Okay, a quick Google search can get you like 4 or 5 studies on BLS versus ALS. The first one I came to is actually from Ontario. And let's talk a little bit about it. The things that they found during this study are actually pretty eye-opening. So they took several different patient types and call types, and they pitted the numbers on like mortality and patient outcomes, ALS versus BLS. So the categories were cardiac arrest, major trauma, respiratory distress, myocardial infarction, and sepsis. Some of these findings they're kind of disturbing, honestly. So when they did the cardiac arrest, they actually found that BLS providers caused a better outcome for cardiac arrest than ALS providers. And they really didn't know for sure. They couldn't pinpoint the exact cause, but the impression was that ALS providers are staying on scene too long to do their interventions, and that was causing a higher mortality rate. It's kind of scary when you think about it. So we're fooling around on scene doing these ALS interventions. Meanwhile, BLS crew jumps in, does their good compressions, takes care of a king in the airway, and runs off to the hospital. And those patients are actually getting higher outcomes than ALS. So that whole argument about we need an ALS provider and ALS providers are lazy. Yeah, that shoots that all to pieces. BLS outcomes are actually better in cardiac arrest. So major traumas. The data is pretty compelling for BLS for major trauma because they didn't see a substantial difference in survival to hospital to discharge between ALS and BLS. So the exact numbers were an 81.8% survival rate for BLS versus an 81.1% for ALS. And in fact, those with a GCS less than 9, ALS care actually increased their mortality rate. And by a significant difference, a difference of 60.1% to 51.2%. So another one of those, BLS actually did a little bit better than ALS interventions. Respiratory distress. So there's a couple of things here that you have to take into consideration. Certain places, BLS did worse than ALS because their protocols were not as, the word I'm looking for is robust. They didn't have the medications that some other agencies did pre-hospital. But in the ones who the BLS providers could give things like your breathing treatments and things like that for respiratory distress, there really wasn't a big difference. BLS was performing just as well as ALS. There was really no huge difference. And in fact, with the addition of CPAP to the BLS scope of practice, it increased it even more. So there's a lot of evidence here for BLS skills are actually working better than ALS. And a lot of it has to do with on-scene times, messing around on scene and trying to deal with all these ALS interventions. BLS is actually performing better. And then heart attacks. So this was another one that was kind of skewed a little bit. It depended on the ability to perform, interpret with a 12 lead, pre-notify the hospital or the correct destination, which obviously shortens the door to balloon time for heart attacks. So the benefit for the patient seems to come from the ability to communicate the critical EKGs to the hospital. Now, with ALS versus BLS here, yes, a paramedic can interpret on scene, go ahead and tell the hospital, hey, I got a STEMI here. I'm going to go ahead and start my pre-treatments before we get to the hospital. My aspirin, nitro, Brilinta, heparin, all of those things. But largely, there wasn't a huge significant difference because BLS providers were able to acquire and transmit an EKG, and the hospital was pre-notified prior to them getting there, and they were ready. So there's not a huge significant difference between outcomes for that either. The only one that really stood out at all, where ALS shined, was early treatment of sepsis. Now, I would imagine and this is just me assuming, this is not actually written in the study. I would assume this matters depending on how far out you are. So if you've got a long transport time, if you aggressively treat sepsis with fluids, with IV resuscitation, I would say their outcome would probably be better because you're getting the opportunity to start flushing that sepsis out. You're taking care of if they've made it to shock, you're dealing with the shock by the fluids, using the fluids. So I would say that's a little skewed depending on, transport time. However, this is where ALS tended to shine because they could start treating pretty aggressively before you got to the hospital. But out of all of these little subcategories, it really doesn't point to ALS being any better, and in fact worse than BLS in many cases. So, getting down to, as they say, brass tacks, the problem, the problem that we're having, I think, more than anything, is the quality of training. For some reason, we've got this issue anymore that our, not agencies, but our powers that be, if you will, are stepping back away from training and putting the burden of responsibility on these training entities like colleges. The state is pushing the responsibility and the burden of training off on their education coordinators. We have a less inclusive training situation now than we used to. We've also took away, and I don't care. You're free to disagree with me. It's a free country, but I'm just going to tell you, since it's my podcast, I'll tell you my opinion. I think it was absolutely a terrible mistake to go away from skills. Okay, and hear me out. Yes, I know they came out with some study a few years ago and said that they literally had providers jumping off the truck and they went through those sheets so much that they would literally say, "Scene safe BSI" out loud. I don't doubt it because I remember going through intermediate, having to learn those skill sheets and know them word for word. I get it. So we had too much emphasis on it. But to quote an old country saying, let's not throw the baby out with bathwater. Why are we throwing out the things that work and completely replacing them with things that obviously are not? And I think what you're going to find with registry right now, registry has went to this, let's go away from skills and put in critical thinking instead of skills. I think that what they're going to find in a few years from now, after they start doing more studies, is that that was a terrible mistake to take out all the skills. Because we've got people, and I've seen it personally. I precept a lot of individuals, both EMT and ALS. They come to our agency and do clinical ride time. And what I'm seeing is you have some pretty smart people. They're not dumb by any means. They're doing well in class. They're bright providers. But they have all this book knowledge. They have all this information in their head and then don't know what order to put it in and have no idea how to perform the skills that are associated with that knowledge. I mean, it's an epidemic. It's become really bad. And I think we're going to run into some problems down the road if this continues. But we're producing providers. Going back to my original point, I'm about to get off on a rabbit trail. We're producing EMTs, more specifically, that have been taught ALS for everything. They can't handle anything. If it's above a sniffle, we're going to have to call for ALS. That's absolutely not true. And the other thing I will tell you is don't wait around for your instructor to spoon feed you the information. It's your responsibility to get in there and study. Look up studies. Study that book that you were supposed to be reading. Look at that those peripheral books that they added in. Like, for instance, with our paramedic class, there was a really good book on capnography. I really enjoyed it. So read that peripheral information. Go to other sources, scholarly sources. Make sure they are scholarly. That's my recommendation to you. Practice, practice, practice. If you have a department that is willing to train, get in there and train. Lay hands on this stuff and strengthen your knowledge. Confidence comes with successful repetition. Sorry, I can't. Apparently, I'm having a stroke. Um, Successful repetition. Completing those skills over and over until it's muscle memory. Getting in there and studying so you won't be surprised. And, oh gosh, I don't know what to do. I can't handle this. We need ALS. Being confident in what you're supposed to be doing Like, if I see this problem, this is what I'm going to do. That is going to strengthen you more than anything. So don't just take my word for it. Look this stuff up on your own. There's many studies out there that talk about how um, ALS versus BLS and resource management. There's a whole discussion out there about this. So maybe some of you have some suggestions. Maybe throw some stuff in the comments if you think of a way that we can improve this situation. Personally, I think it starts with training. I think since these higher agencies have kind of pushed some of this off on the individual agencies and companies themselves, then I guess we really need to take responsibility and start picking up the slack. We've got to get these providers in a place to where they're confident. And as I said, you may not have this problem where you work at, but it is a problem in other places, specifically more rural places. So, but anyway, that's all for this one. Thank you for listening to my first podcast. Hopefully, I'll get some different equipment. We'll hit some more important subjects. We'll talk about some training, and hope you enjoy. See you next time.